We will come for the second speaker, Mr. Belal Alblowe. Belal is a nurse professional specialized in hematology and bone marrow transplant. He has a PhD degree in nursing from the Hashemite University and master degree in nursing from Zarqa University. Belal, he is a professional career at King Hussein Cancer Center while he's working for almost 6 years. As a BMT nurse and BMT clinical coordinator. He lately joined the King Fahd Specialist Hospital in Dammam, served for 9 years as a BMT clinical coordinator. Now he's working John Hopkins Aramco as a coordinator specialist. Throughout his career, he's also participated in multiple research projects related to hematology and bone marrow transplant. We're honored to have you, Belal. Mic for you.
Thank you, Suha, for the intervention. Thank you all. Good afternoon, all. I would like to, first of all,
Excuse me, Belal, your slides and your name.
Okay, to consume the time, let me thank the organization team to invite me as a speaker in this event, the SSBMT. This is the second time for me, and I appreciate it. Today, I would like to talk about the nursing experience and care for the patient receiving cellular and bispecific antibody therapies. When I talk about the nursing experience, I'm talking about the knowledge. I'm talking about the information that the nurse must gain to have a confidence work when he deal with a complex patient who will receive cellular therapy by specific antibody. This is me. And I will start with the first of all, I will just identify what the meaning of empowerment, because the empowerment, it will give us to it's provoke us to start with this complex patient. So the empowerment, it's referred to the process to give the nurse the authority and the resource and the confidence to support they need to make the decision, take initiative and lead in the healthcare setting. Without this component, without these three components, I don't think that we have experienced nurse or motivated nurse to deal with a complex patient who will receive cellular or bispecific antibody. All of us agree that without this component, without satisfaction, I don't think that that we can deal with like this patient. So what's the key and the aspect that we must have to have this empowerment? First of all, I will back to the knowledge, the information. Without knowledge, without information about the case that we are dealing, about the disease, about the complication, about the medication, about all of this, about the new generation for the medication, I don't think that we can deal with the patient. If I am a apheresis nurse, I know that when I did the stem cell collection or I did the lymphocyte collection, I will face the numbness. The patient, he will face the numbness. If the patient, he complains from the numbness, I will be comfortable because I know this is one of the complications of the apheresis process. If I don't know this information, I will be panic, and I cannot act with this incidence if I don't have the knowledge. So the education and training, it's with the complexity of the BMT patient, with the CAR T-cell patient, with the patient who will receive bispecific antibody, it's must for the nurses. So this is abstract, this research talking about the CAR T-cell therapy, and it's approved that nursing care and knowledge, it has power and it has impact for the patient who will receive CAR T-cell therapy, and it has positive impact for the patient. And another research talking about the impact of the nursing knowledge and nursing motivation to decrease the length of stay for the patient who will receive bone marrow transplantation, and CAR T cell. This is very important, and I think this is remarkable to you. If you have this, to do the research for your patient, if he has any scoring before, motivation score, if he has this motivation score, if there is any impact for this scoring system for the patient who will receive CAR T cell or allogenic transplantation, the patient who has less marker, I think he has more length of stay and he has more complication. All of us knows if the patient has low appetite for the treatment or low satisfaction, he will has a lot of complication. Another key and aspect that I will mention, the resource. I will back to the resource, knowledge. And when I talk about resource, I'm talking about the resource, the tools, the physical resource. For the nurses, the equipment. If he has equipment, which means he can do his work. And another things, the evidence-based practice. When he did his work depend on evidence-based practice, he will do it with high confidence. And recognition and respect, it's valuable to do every time for the nurses contribution and to just motivate them to do their work. So the next, I will just mention the environment for the nurses, which means the nurse who handle the CAR T cell and cellular therapy patient, who will deal with a lot of the teamwork. He will work with pharmacy, pharmacist, he will work with nutritionist, with radiologist, with all this team. If there is any failure in this process, which means there is failure with the quality of life for the patient, it will affect. And adequate of the staffing, if the nurse, he handle 5 patients, 6 patients, all of them, they are cellular patient or they are CAR T cell patient, I don't think that the quality of work, it will be improving. So the manager, they have to follow the criteria of the patient ratio for the nurse who handle the complexity of like this patient. So all of these components, it will affect the improving patient outcome. As I mentioned before, it will improve the length of stay, higher job satisfaction. Like Magnet, I think a lot of hospitals here, they has Magnet professionalism and enhance teamwork and increase innovation for the nurses. Now I will just go to the very important topic in my slide. I will talk about what's the role of the nurses when they are dealing with the CAR T cell or cellular or bispecific therapy. Now, the first of all, education. If you don't have that knowledge, you cannot do this part. You don't have the knowledge of the complication. You don't have the knowledge of the medication that you will give to the patient. So how you will give the information to the patient? If your patient asks you, he will see you. He will attend the clinic with the physician, and after that, maybe he will gain only 10% from the information in the clinic because he's confused. When he hear about the CAR T cell, all of this complication, CRS, all of this complication, so he will be confused. Maybe he will gain 5 to 10% only from the knowledge. After that, he will depend on you to provide with good knowledge. I remember we did a YouTube channel for the patient, and we make just a brief with the allogenic transplantation patient, with the donor, the process. And usually we give this YouTube channel for the patient. Please watch it in your home. Then back next day to ask the question. Because the patient in the clinic, he will not be concentrated. He will not be focused. So he will depend on your knowledge to give him daily knowledge, even every day. What's the schedule of today? Describe the potential of the side effects. Same. If you don't have the knowledge, you cannot. If you don't know what the meaning of the CRS, what happened? How can I prescribe the CRS? What's the grade of the CRS? how you will prescribe it for the patient. If the patient has a knowledge of the CRS and the grade, he will he will collaborate with you. Even, okay, I feel that I have a grade 1, grade 2, if the patient, he has good information. Psychosocial support. This is, I think this is crucial. And this is also all nurses, they are creative to do this part. I think we have Daisy Award, we have all of these patients, he will write letter what they are doing with the patient. Apheresis and cell collection. This is the first process, I think, with the CAR T cell and the stem cell. It will be the same, the collection of the lymphocyte, but we have here challenge with the CAR T cell collection. Why? Because the number of the lymphocyte, it will be less than the usual number that we are facing with the donor, healthy donor. Why? Because the patient, he is exposed to chemotherapy, he's exposed to a lot of therapy that it will deplete the lymphocyte. So it's challenging. So this is the first part, apheresis, administration of the CAR T or administration of the chemotherapy or bispecific antibody. So you will be sure that it's available and all the component, as we mentioned before, it's available, line available, consent available, pre-medication available. And if the medication of any complication that it might happen, all the medication, it's available around. The cell infusion, all of us knows the consent and the thawing, it will be in the door of the patient or inside the room. And you will check double, triple, 4 times with the consultant, with all of the body. You will check this cell, it's back to this patient, and you will verify with all of the team, and you will do the thawing. The thawing, because the cell, it will come from the manufacturer, it will be frozen. Then the thawing, which means back to the liquidity and to give it to the patient, and you have the IV axis, because all of us know that it has special IV axis. Or usually the patient, he has big line or central line. Cell infusion, as I mentioned, the cell infusion are infused as per cellular therapy administration policy. The patient vital signs are recorded during and following the infusion. All documentation is completed. The infusion is usually uneventful, but intensive care and neurological, they has to be on board, because all of us knows about the difficulty that maybe we are facing after the infusion. So the patient monitor, if I know all the steps and the monitoring what I will do, this is me, I am panic. Why? Because maybe I saw some symptom for the patient, and this symptom, it's worsening now. This CRS, it's jumped from grade 1 to grade 2, and from grade 2 to grade 3. So the vital sign monitoring, especially during and after the infusion, it's crucial, and especially after the infusion. Why? Because the CRS, it's depends on the vital sign, if the patient has fever or hypertension or hypoxia, low oxygenation, or if there is any neurological event. The two most common toxicity, as we know, for the CAR T cell is CRS, cytokinase release syndrome, and immune effector cell associated neurotoxicity syndrome icons. How we can manage this, or how we can classify the CRS? All of us, we are familiar with the CRS parameter, the 3 parameter, the body temperature, and the blood pressure, and hypoxia, autosaturation. Grade 1, if the patient has only fever, less than 38 Celsius, but he has normal blood pressure with normal oxygen saturation. Grade 2, the patient, he has still fever more than 38, but he start to have hypotension, but not require vasopressor. It's manageable with IV fluid, and regarding the oxygen saturation, require low flow oxygenation, not high flow. The grade 3, it will still patient has fever, and he require vasopressor, which means ICU onboarded now. And the ICU, they are onboarded from the beginning that we have CAR T cell. It's alarming for them, because they have to have a knowledge for the CRS and how to can deal with the CRS management. Grade 4, the severity. Patient has fever and hypotension, require a multi-vasopressor line, and the oxygenation, it will be low and require high volume with CBAB or BiBAB. So this is the monitoring that we are talking about. ICANS also score. We are initial have ICE score. The ICE score, it must be done before the CAR T-cell infusion. Why? Because it's baseline for us. Now we are, when we talk about the ICANS score, ICE score, we will know why we are doing the baseline before the CAR T-cell infusion. We have to have the baseline before to compare it if the patient has deterioration from this score or not. If the patient has deterioration, which means he jumped from grade to grade and he has, each step he has a modality of the treatment and criteria to treat this patient. So what this, usually the ICE, every 8 hours after the infusion, I will check it and BRN if there is any recommendation of the patient. If I see any change for this patient, I can repeat the ICE score for this patient. But usually, if there is nothing, I have to check the patient every 8 hours after the CAR T cell, and I will compare it with baseline that done before the CAR T cell infusion. This is the ICANS score. It's from 0 to 10. There is 4 score talking about the orientation for the patient. Orientation, which means I will ask him about the what we are in this year, which year, and it's by more specific the month, and what the city that we have, Dammam, Riyadh, or where we are, and what the hospital are you in, if more specific. So it will start with a big question, which year, then will we minimize it to be which month, then we can minimize the city, okay, and then more specific, you are in which hospital, okay? So if the patient, he answer me for this question, he will get 4 points. Then he will jump to if he can recognize the 3 objects. So any object around you, TV, pen, so it will be familiar object for all of patient. Don't give him object that he don't know about it. Don't give him like bad package of CAR T cell or modifier to give him what is this? He don't know. Of course, he don't know this object. Okay, so and if he knows this 3 object, he will get 1 point. And if he can following the command, he can also has another point and rating. And you will verify if the patient know how to write, because not all the patient knows how to write. If the patient he cannot write, just let him to draw circle or draw any
3 minutes
any
more.
shape.
3 minutes more.
Attention, if the patient he can count from 100 to 10, 119, 18, 70, he will get another point. So this is 10 out of 10 if he can answer all this question, and then I will follow this I can score each 8 hour ICE score. So this is one of our hospital, they are dealing with this questionnaire, and it must be filled by a nurse, by experienced nurse, professional nurse. So the toxicity and management, we are talking about CRS and ICAN, which mean treatment of symptom is key nursing rule in the management for bispecific antibody and CAR T-cell toxicity. Patient with suspected CRS require maybe antibiotic and IV fluid. And as a first line with treating with the CRS, they are treating with teclistamab, and it's monoclonal antibody given IV. And we can give up to 4 doses can be given for the patient at least 8 hours apart. And the second line, corticosteroid, as all of us knows, but it will be the first line for the ICAN because the teclistamab, it's not penetrating the brain tissue, so it's the first line. But we have just to focus to not just I will focus with this slide, and I just forget to focus before as a pre-medication. CAR T cell, we will not give corticosteroid steroid, because the corticosteroid, all of us knows, it's lymphodepleted, and it's against our target, and it will just make a problem with our product. So corticosteroid, we will try to avoid the corticosteroid even But if it's the complication, it will be grade 4 or severe. Maybe at that time we can give corticosteroid. So also another part for the nurse is coordination of the care, and this is one of the coordinator work to coordinate all of this with the patient, and finally discharge if the patient he has good shape and he's fit for discharge. And documentation and reporting, it's very crucial for this. All this reporting, they must fill the ICE report each 8 hours and before, and vitally it's crucial for all the patient, because it will maybe back to this documentation to know what happened with the patient and how we can deal with this. So this is me, the first infusion. It will give me the empowerment. This is first stem cell transplant, was done in King Hussein Cancer Center in 2010. Thank you very much for your attention, and if there is any question, I am here.
Thank you so much, Belal. Any questions? Because Belal, he needs to catch his flight. Any question? Nothing? Okay, thank you so much, Belal. Appreciate it. Don't forget to take your certificate. Appreciate. We will go for the second, yeah, clap for him.